Сейчас начинается, как я уже упомянул, одна из самых важных частей нашей встречи. Это лекция профессора Тисдейла, сэра Тисдейла, о шкале Комы Глазго. Но прежде чем передать ему слово, я попрошу Настю Чумакову представить сэра Тисдейла. Пожалуйста, Настя.
Сэр Грэхэм Тисдейл родился в городе Дарем, это на северо-востоке Англии. Он поступил в Даремский университет, который с отличием окончил, и прошел резидентуру в городе Глазго в университете. В том же месте он начал преподавать, делал это весьма успешно, и уже к 1981 году он был назначен заведующим кафедрой нейрохирургии университета Глазго. Но, конечно же, в течение этого времени он также занимался наукой, изучал процессы ишемии при черепно-мозговой травме, адаптации, воздействия различных веществ на восстановление больных с черепно-мозговой травмой. И стал одним из создателей шкалы Комы Глазго, который на сегодняшний день повсеместно используется неврологами, нейрохирургами всего мира. С 2003 по 2006 год профессор Тисдейл возглавлял Королевский колледж врачей и хирургов университета Глазго, и в 2006 году был посвящен в рыцари за заслуги перед нейрохирургией. So, ladies and gentlemen, please welcome Sir Gрэхэм Тисдейл.
It is a very, very great pleasure to be here in this world-famous institute that has given so much to the field of neurosurgery. It's a pleasure to renew friendships that began with Professor Konovalov in 1978 in Paris at a European meeting, which then were renewed with Professor Potapov at the European Congress here in Moscow in 1991. But the story that I'm going to deal with this afternoon goes back even longer, goes back to 40 years ago about the Glasgow Coma scale. And I thank Anastasia for those kind words of introduction. So why is a very simple clinical assessment method so interesting after 40 years? Well, that's what we will look at. I will start by considering some of the reasons that it was important to develop an approach and the factors that we took into account in our development. I will then say something about events over the next 40 years, how it's been applied, the information that's come from its use. And at the end, I will look at the question, well, where is it now at 40? Is it old? Is it obsolete? Or does it have a future? And that really is the question that we'll end with. Of course, the topic of impaired consciousness is absolutely basic in the management of any patient with an acute brain injury. It's needed to describe how these patients differ from each other. It's needed to track the course of one patient through their illness. It's an absolutely basic aspect of neurosurgical, neurological, and neurocritical care to assess how the brain's overall function has been impaired by whatever primary specific diagnosis has caused the problem. And it's clear, even after all this time, that the extent of impaired consciousness is a key indicator. How deeply someone is depressed in consciousness in the early stage and for how long is really the best indication of the initial clinical severity of the insult. And assessing the person time after time to see if they're improving, deteriorating or stable forms a large part of the work of staff in neurosurgical units and in trauma units, particularly junior doctors and nurses, because this is the basis for decisions about management. Going further down the line, in terms of outcome and prognosis, it is a very good guide to the visual severity of injury and what can be expected later on. And in research, it's a fundamental yardstick to compare patients treated in different ways, either in the same clinic in trials or in different clinics. So it's an absolutely basic part of our clinical practice. Yet in the early 1970s, when we started looking at the position, it was chaos. No one system of consciousness assessment had gained widespread assessment. And these are just some of the examples that we found in use at that stage. And they ranged in the number of levels of deterioration or improvement that people thought were relevant, from 4 up to more than 20. And they were described in varyingly, totally different ways. Terms such as coma-vigil, non-verbal purposive, somnolent, obtundation. What do these actually mean? Not sufficiently clear and precise to take clinical decisions on. It was almost as if every clinic had their own system. They might know how it worked, but was different in another clinic. So communication about patients being transferred was poor, and communication in research was impeded. So we felt we had to do something to try and get a more consistent system that might be widely acceptable. And after 3 or 4 years of trying different approaches, we came up with the method that was described in the Lancet in 1974. Myself and Brian Jeanette, my senior professor then and my mentor through my career. And it emphasized for the whole spectrum, not just severe coma, but minor impairment of consciousness, and a practical scale. This was developed to help practical communication, not on some theoretical basis. And the scale was evolved to look at duration and depth of coma. Instead of having levels with things compressed into steps and ladders, we thought it was best to assess 3 different aspects of the person independently. This is how the scale came to be made up of the motor response, the verbal performance, the eye-opening, and so on. And the summary says how we tested it for display and use by junior doctors. So that was what we said way back in 1974. In our thinking, in developing and promulgating the scale, we thought there might be 5 major aspects that we'd want to see it have if it was going to be useful. It had to be practical, the kind of thing you could do any time of the day or night, any day of the week. Some of the systems depended upon doing EEGs, which might be informative, but they're not there on Saturday or Friday night. And certainly in Glasgow, most head injuries occur on Friday and Saturday night after the public houses close. I don't know the situation in Moscow, perhaps not too different. So it had to be practical, could be done by junior doctors and nurses. And because of the importance of monitoring the person's condition, the trend, had to be something you could see quickly and assimilate how the patient's condition was changing. Had to be repeatable, have good observer consistency. Our main aim was to have a communication system, but if it was going to be relevant, it needed to show some sensible relationship with the underlying degree of brain injury severity in the early stage and later outcome. And hopefully, because of the way the head injuries occur throughout the world, in all sorts of hospitals, in all sorts of care, widely acceptable wherever they've been cared for. And the system was simple to do. It involved observation of the patient at rest and response to simple stimuli. The recording of it and display of it was described a year after the original scale in a nursing journal, the Nursing Times. And this was developed with our intensive care unit nurses. And I think this was the key in having the scale picked up by nursing community in many places, because they found this very valuable to their work that made it more meaningful and more useful. And On the left here, this shows a picture from the original Lancet paper, how the eye, verbal and motor responses were assessed and also charted separately. And now you can see how someone is going along. Their condition worsens, clearly. Now, this was not because we weren't doing anything. This was in the days before CT scanning. The person was thought to have a swollen brain and was being treated with ventilation, mannitol, and steroids, and that clearly wasn't working. The craniotomy was done, and the person had a burst lobe with a subdural cerebral hematoma, was evacuated, and the monitoring showed clearly how the person responded to that intervention. Very graphical, very easy to know what's going on. And this chart here, incorporating the Coma scale with blood pressure, the traditional vital signs and focal signs, was described in 1975 and has now been picked up in many parts of the world. So that answered the first two things, practical and easy to record and display. And then we started thinking, well, how does it relate to severity? And how do we start getting information about that? Well, we had to collect information and enter it into a computer. The scale, 3 parts, each subdivision described by words, but you couldn't really enter words into the computer in those days and make sense of it. So we thought what we'll do is we'll give each of the steps a number, and then you can enter it into the computer. Eye opening 3, verbal response 4, motor response 6, whatever you like, and made it easy to go in. And so we collected lots of information on patients looking at the individual responses. But then we came to look at results. And having graphs with 3 dimensions was just a bit too tricky. So that what we could not resist doing was to add all the steps together. And that is how we went from a scale, which is a verbal description, to a score, which ranges from 3, which you can see why that's the bottom, up to 15. And the two things, the scale and the score, have different benefits. Scale is a clear way of telling what a person's like. The score provides an overall summary of severity. And our advice then, and still is, that when you're talking about an individual patient, you should describe them in the 3 parts of the scale, describing them in words, and that creates the most clear picture to communicate to someone else or to your own records as to how the person is. On the other hand, if you want a very quick summary, particularly in groups of patients and comparing them, the score is useful then, and it's provided a very useful index for classifying patients for various research studies or guidelines. So each of them has its merits. And what we found through our research and from research in many other clinics was that the overall score showed very useful broad correlations with investigative indices of what was going on inside the head. So this is looking at the relationship between early brain damage as shown by investigations. The lower the score, the worse the EEG, the worse the evoked potentials. The lower the score, the more likely to have high intracranial pressure, low CBF and low CMR2. And imaging came along and it became clear that there was a very useful correlation between the score and results of imaging. These show data from 10,000 patients studied in the steroid study, the CRASH study, relating the coma score on admission to the prospect that the CT scan will show an intracranial hematoma that needs to be evacuated. Now, in the CRASH study, they didn't take patients with 15, which is why the score goes from 14, where about less than 5% will have an operable lesion, up to down here, where you have 1 in 5 patients with something that needs to come out. Very useful correlation, and very useful in developing clinical guidelines. That was CT. This is an example very close to home, which Alexander kindly showed to me in Prague in October. This is from the book published from the Budenko just recently, from MRI lesions in either the thalamus or on the brainstem, here related to the coma scale, going from 3, the most depressed, up to 15 normal. And it's a fascinating, almost linear trend that as the coma scale drops, so the likelihood of thalamic lesions on MRI increases. And the thalamus is a key in integrated brain function and a key factor in impairment of consciousness. But by contrast, interestingly, brainstem injury only starts to become important in the more deeper aspects of coma. So here, a very nice example from investigation at Videnko of this practically useful relationship between the coma scale and imaging of the brain. So it correlates with these early investigative things and also with outcome, either in terms of early mortality or later recovery. These are data from a North American trauma data bank reported by Tom Generelli and his colleagues from Philadelphia, in which they had data on 47,000 head injuries. To be able to collect that number of patients speaks to the practical ease with which the scale can be used and employed to treat patients and to conduct research. Again, from 3 at the bottom here up to 15, the red line shows the numbers of patients with different scores. It's no surprise the high numbers of patients with mild impaired consciousness, the mild head injury, which we know are the great bulk of head injuries coming to intensive care units. And then usefully almost equal numbers in the different blocks as it goes down, nicely segmenting it. And then down to 3 here, where some of these are pseudo-3s, people actually paralysed and ventilated, given a score of 3. And what you see in the pale blue line is a mortality rate, and in yellow, a fitted line, indicating a continuous, smooth relationship between how much consciousness depressed, according to the coma score, and outcome, mortality in the acute stage. And that relationship persists into late outcome. That's also crash data on mortality. I'll go to this one. These are data relating the coma score and admission to hospital to what happened in survivors 6 months later. So the dead people are out of this. And what we see here, apart from the funny 3s, again, this relationship with now the increasing prospect of good independent recovery increasing along with increasing responsiveness judged by the coma score. So the relationship is so powerful, it's still expressed 6 months later in terms of the quality of recovery in survivors. So these and many other studies really confirm that there is some sensible relationship between the score and underlying brain damage. So how did it become picked up widely? I've mentioned the nursing networks. We were lucky. The time was right because head injury management was becoming controversial. I mentioned the use of mannitol, steroids, and so on. And these methods were being employed in the early 70s. There was debate about how useful they were. Brian Jeanette organised a study in 3 different countries, compared how these management techniques were used in different frequencies in different places, but it didn't affect the outcome. So the statement in this paper was that differences in how much you use steroids and mannitol and ventilation and so on didn't crucially affect outcome, an objective statement of fact in those data. But exactly the same year, a paper came out from Richmond in Virginia, from Don Becker and my friend Douglas Miller, saying almost the reverse of that. Vigorous therapy, use everything you can, and some people who die will make a good recovery. 2 polarized sort of statements. And this created great controversy. People were saying, who's right, who's wrong? Are the Glasgow people and the Richmond people going to fight at meetings? And meetings were interesting, and it stimulated research, it stimulated young people to come to the field, and I think had a great boost to making head injury an interesting, exciting area of neurosurgery, whereas previously been a backwater. So it became the language to be used in these studies. And over time, there have been great advances in the management of head injuries. Pre-hospital care has improved, resuscitation's improved, scanning's come along, intensive care, and the coma scale became a common language used to talk about these different advances, to talk about their benefits, to compare them, and it was the language that was used for research and clinical care of patients. We were lucky. It was the right time, and it was picked up. So, as we come more up to date, where are we? A year ago, knowing that 1974 was 40 years ago, the Lancet Neurology invited some of us to do a review article on where does the coma scale stand 40 years after. We sent it in and said the Glasgow coma scale at 40 years. They added on standing the test of time. That was their words. And what we did was we reviewed articles, not all of them because you'll see there are thousands, but we reviewed the major review articles to see what messages came out. One of the messages in all the articles was the coma scale is widely used. It's widely accepted. But that's not really data. There was no firm basis apart from anecdote to give support to that. So what we decided to do was to do a survey of the member societies of the World Federation of Neurosurgical Societies. And we contacted, through the World Federation, the secretaries of all the national societies. And in the end, we received replies from these countries, more than 80 countries. Not all, but there were places you could understand. Sudan, Syria, Iraq, that weren't able to respond. But I think virtually every major country in the world responded to our questionnaire about the use of the coma scale. And what we found was, in the 84 countries that had responded, everyone in every country, they were using the Glasgow coma scale to assess their head-injured patients. And in almost all, they were using it for other neurosurgical patients as well. And in almost all countries, it's not just neurosurgeons. It's been accepted by the emergency department people. So it's been widely acceptable in terms of geography and accepted across specialties in the way that we hoped. An interesting thing was we asked people, is it used in English or translated? And we found that it's been translated into 60 different languages across the world. So I think our hope for wide acceptance has been backed up. The number of citations to the Lancet paper grows and grows. These are the citations from the literature in Web of Science, which is the most rigorous citation analysis system, to the paper, starting back in 74, going up to 2013. And you can see that every year the number of citations to that 1974 paper goes up and up. Now 300 citations a year. So I think this is why the Lancet said it is standing the test of time. It shows no signs of dropping away into old age. And the total citations in Web of Science is 5,500. If you go to Google Scholar, you get 20,000, but that's not a rigorous method. It's 5,500. Of course, since 1974, other systems have been proposed in different countries, different places. We looked at 18 of those, and in total, for the other 18 scales, they came to 680. So I think it's standing the test of time against other more recent suggestions. None of them look like taking it over. And work from people in Montreal, Andres Lozano and Ponce, looking at neurosurgical classical papers, showed that the coma scale paper is the most cited neurosurgical paper of all time. So again, I think an index of acceptance of tiny test of time. But nothing is so simple that you can just put it out and forget about it. And one does have to go back and think about how it was developed and how it should be used. And now, coming towards the sort of conclusion, 2 words of caution. People tend to sort of think the coma scale can do everything, that it's sufficient to classify head injuries, sufficient to do prognosis. No, it was meant simply to add a reasonably objective, consistent assessment of consciousness to the other information, to information about brainstem function, in pupil reaction, about age in investigations, so on. So that in classifying patients, combined scores with coma scale and scans, whatever, yes. In prognosis, multivariate models that I'm sure Andrew Masters talked about, combining clinical and other features that should be used. So it's important, but it's not the only thing. It needs to be seen in the context of the overall assessment. And what we realized was that this widespread dissemination has had a downside. It's had an adverse thing, in that as it's been spread, people have increasingly developed their own way of doing it. Having started to try and get a consistent approach, different places have started assessing it in different ways. And that's contributed to its reliability between observers being not as good as it used to be. And inconsistency is the very thing one wants to avoid. And one of Andrew Masters' residents, Florence Reith, did a survey at the beginning of this year asking other neurosurgical trainees in 48 countries what techniques to use to examine people doing the coma scale. And you can see there are 7 different ways of stimulating the patient in use. Now, anything more likely to reintroduce inconsistency, difficult to think of. And we felt it was time to restate the fundamental principles and to set out a kind of updated gold standard method of doing the coma scale. So we've produced a website, reference at the bottom there, glasgocomascale.org, on which we set out the approach to assess eye-opening, verbal and motor responses, and with a bit of luck, I will just show you a very brief clip from this. Hey! Working.
When assessing a patient, there are 4 steps: check, observe, stimulate, and rate. The patient is rated in each component by matching findings with the corresponding criterion. There are 4 criteria for eyes, 5 for verbal, and 6 for motor score. If the patient's eyes open spontaneously, spontaneous is recorded. Remember, there may be local factors, such as swelling, that prevent eye opening. If spontaneous opening is not demonstrated, a verbal stimulus is used by introducing yourself clearly and requesting eye opening, if necessary by shouting. If the patient opens their eyes, to sound is recorded. If the patient does not open their eyes when you speak to them, a physical peripheral stimulus is then applied.
That's just a very brief sort of trailer. The whole video is only 7.5 minutes, and it's very easily seen. And we hope it will be very valuable teaching aid in developing new staff, nursing, neurosurgical, and provide a standard approach for people to go back to as the consistent method. At the end of the video, there's a downloadable summary of the approach, which is seen here. That can be downloaded by people and used as their guide to doing the coma score and coma scale in what we hope is a consistent way. So, is that the end? No, well, of course not. In today's world, simple websites and videos are only a start. And for those with iPhones, there is already a GCS app on the iPhone, and our plans for next year are to put our video onto an iPhone and to produce that summary chart translated into the 60 languages that the coma scale has been translated into. So, I started off by asking, well, at 40, is the Glasgow coma scale past it? Is it going into old age and history? Or is it fit for the future? I think we're doing our best to make it fit for the future. Thank you very much indeed.
Thank you, sir. Please. Глубоко уважаемые коллеги, решением ученого совета Института нейрохирургии профессор сэр Грэхэм Тисдейл награждается званием почетного профессора Института нейрохирургии имени Бурденко. So, by the resolution of Academic Council of Burdenko Neurosurgery Institute, Professor Sir Gрэхэм Тисдейл is awarded with an honorary professor title, diploma and mantle of Burdenko Neurosurgery Institute. Congratulations. Пожалуйста, торжественная музыка.